Now, you can tell I'm burbling away, and Mita, when do you think we are allowed to start? Tell me the...
Yeah, Prof, I think it's okay to start.
Okay, oh, good. Joe, would you like to share screen and start your case presentation? Thanks very much. So Dr. Joe Koo is one of our registrars in ophthalmology. Thanks, Joe.
Thanks. Thanks, Prof. Thanks for having me here to talk about this very interesting case. So my case is on looking beyond idiopathic intracranial hypertension, whereby we had this patient who is a 19-year-old female who presented with 4 weeks of acute onset headaches. That's worse in the morning, lying flat. There was no pulsatile tinnitus, no neurological symptoms. But interestingly, her BMI was normal, it was 24. She did have some Roaccutane use 6 months prior, but not at the time. And her vision was actually quite good, 6.6 in the right and 6.7.5 in the left. And examination revealed at least a grade 3 papilledema here. And that's shown on OCT as well. And her visual field, fortunately, is not too bad, as you can see here.
Don't rush, Joe. You're tending to rush through the slides. Let the audience have a...
Yeah, so that was
maybe just... You might just want to explain this type of visual field, because this type of visual field hasn't been seen by...
Yeah, this is a very this is one of our new machines here called the Compass. It's a very good modality in that it shows actually the photo of the disc, and at the same time it shows this. I've not come across many of these, Prof. I might need your help with this a little bit, but
it actually tracks the retina in real time as the patient is doing the test using infrared tracking, and it projects the stimulus directly onto the point of the retina that it wants to, that it's programmed to do so. Whereas pretty much all the other field machines use a grid, which is a best guess grid. So it's actually more accurate. But here, as Joe was saying, it is normal. But it also takes very nice photographs of the optic disc.
And you can see here it shows a very nice segmentation of each of the important segments that comes out of the optic disc here in MDs, mean deviations. So to carry on, the blood pressure for this patient was normal. We did an MRI, MRV that showed no venous thrombosis, no stenosis. There was no space-occupying lesions either. The lumbar puncture opening pressure was 40, it's quite high, but the CSF constituent were all normal. And there was an incidental finding of a high platelet count of 613. And so the hematologists were involved as well in this case. And the patient was diagnosed to have essential thrombocytopenia, which is called ET, which I'm going to talk about a little bit more later. So the patient was managed from the ET point of view with hydroxyurea, PEG interferon, and aspirin. And from the IIH point of view, we started the patient on Diamox 375 milligrams QID. And of course, the patient improved very significantly before and after, you can see here. And just a little bit about ET. It's actually a myeloproliferative neoplasia, very little known until very recently. It's become more, the medical world has become more aware of this MPN. I actually spoke to one of my friends who's doing a fellowship in the UK under one of the very prominent specialists in this MPN disease. It's a very it's not a common disease. Only 3 in 100,000 cases. and they present with high platelet counts. And the reason it's been categorized into a blood cancer, MPN, is because the platelet would be produced uncontrollably, and that's why it's been categorized as a cancer, and it's been known to transform into a leukemia as well later on. Now, there's only one case report, as you can see here, that associates BIH. Back then in 1989, it was still called BIH with ET, and that was the only case report. However, we know that the presentations for ET, they do present with persistent repeated headaches, visual disturbances, and silent migraines. Perhaps the awareness of ET is just quite recent, and perhaps people haven't been looking into the eyes enough to actually diagnose IIH in these patients, is what I'm thinking after discussing with my friend as well. So the take-home point of this case is really to look beyond just idiopathic IIH, especially if the patient falls in the category of atypical IIH. And in this case, the BMI was definitely below 30. Other things to look at for if the patient is a male, then you got to look for other causes, such as any history of thrombosis, any use of vitamin A compounds like isotretinoin, minocycline, doxycycline, tetracycline. And it's important to actually ask, especially in young females, what sort of medications they've been using for their acne, including lots of medications that's actually over the counter or sold by, those, I call it pyramid scheme for skin, all these medical or non-medical skin therapy. So it's important to get them to bring it in and look through the numerous things that's in the bottle. And other things like lithium in bipolar disease, steroids used, especially if when they're withdrawing the steroids dose, cyclosporine, and oral contraceptive pills as well that can cause venous sinus thrombosis. Yeah, and this is a very good guideline on diagnosing and managing IIH that I've come across. If anyone's interested to read about IIH a bit more. And that's the end of my case report. Thanks.
Thanks very much, Jo. And I'm going to take a liberty here. I think the person who really diagnosed this was Neha Irani. I think Neha referred her to me after the diagnosis was made, because we're doing a study using photoplethysmography. Jo, were you going to show any of those results, or you didn't include those?
Actually, I did. Sorry about that, Prof.
That's right. But as far as I was concerned, I really consider this to be idiopathic intracranial hypertension, but Neha knew better and did the medical tests. And I think
so I'd like to, sorry, can I a few comments? Thanks, Jo, for presenting her. Look, this is incredibly rare, the presentation, but the main point, as Jo was also sort of alluding to, is when we diagnose IIH, which has become quite a common condition to diagnose, there is still a sort of a framework we want to work within to get to the point of calling something idiopathic. And idiopathic essentially means we don't have a cause. So for us to say we don't have a cause, we need to go through various causes that could potentially cause raised ICP, because all we have at the start of a presentation is someone who's come in with symptoms suggestive of raised ICP with papilledema, given that she had bilateral optic disc swelling with preserved visual fields and preserved visual acuity, and a CSF opening pressure that was high. So neuroanatomically, as we always often like to say, this is definitely raised intracranial pressure. And then before we jump to it being idiopathic, you have to think about various causes. And this young girl who was not overweight, which was quite important, but had used Roaccutane 6 months ago, and that is a well-known association, but yet there was no, temporal correlation with why she presented. So as a routine, I do full blood counts and also iron studies in all my young patients who potentially have IIH, okay? And then depending on their background history, we will probably look for other metabolic causes. Obviously, in her case, her platelet counts jumped out a little bit, and both her parents were actually doctors, and they knew of the platelet count being up, but hadn't thought much about it because it was sort of borderline up. I also do stroke neurology. Normally, when I see young patients with strokes that have a high platelet count, we look for a JAK2 mutation, which is essentially what the problem is with essential thrombocythemia. So we tested for that, and that came out positive. Now, essential thrombocythemia is rare. However, it is one of the commoner myeloproliferative disorders. And it actually presents in sort of females, but more in the 50s and 60s. So it was really unusual that this young girl who was 18 or something years of age had essential thrombocythemia and IIH, which was also atypical given that she wasn't really in your typical demographic. So you have to beg the question whether there is a link here or not. And there's been about a handful, about 3 or 4 case reports since the 1988 one, including that has been published on this. And given the rarity of both of these conditions for her specific presentation, I suspect they're related, and it is not infiltration of the central nervous system because the CSF was bland. So that's the other practical point. Before we say something is IIH, you absolutely want to make sure that the CSF doesn't have high protein or high cell count, etc. Hers was completely normal. So as Prof. Morgan said, this is behaving like IIH, not like an infiltrative problem of the CNS. However, I do think that the essential thrombocythemia is the driver or the risk factor for her presentation. And we've thought about this back and forth. I've spoken to a hematologist who hadn't seen this before, but does have another case we dug out. So we actually have 2 other cases that have one is a polycythemia vera, which is also a myeloproliferative disorder in a middle-aged woman, but also has IIH, but she's obese, so one could argue those 2 are sort of concurrent disorders. And the other one, I think, was also essential thrombocythemia in a skinny woman. So again, I do think there is some potential link there. And I know we talk about lymphatics a lot these days. And maybe there is something to do with the problem with reabsorption of the CSF in someone who has an excessive bone marrow production of, a mutation that's driving excessive bone marrow production of these cells. And she did respond to, so initially though, and that's where Prof. Morgan's plethysmography was quite useful, because when she first came in, the images that Joe showed us was at least 2 months down the track. She first came in with grade 4 papilledema. I think grade 5 in one eye because there was some hemorrhagic spots as well. And for a skinny girl, a pressure of 40 is quite high. Usually are obese, and there is a correlation with the obesity and your intracranial pressures. So for a skinny girl, 40 is high. So the first week, I probably did about 3 lumbar punctures, and the pressures kept going back up. And then instead of, and I had her on high dose Diamox, but then we monitored her with the non-invasive testing with Prof. Morgan. And that sort of led us to convince the hematologist to treat her essential thrombocythemia, which within sort of a couple of weeks of starting her on hydroxyurea and aspirin, the pressure started to come down quite gradually, but also in relation to the medications. And then she was well and truly outside of, concerns for vision loss once the swelling started to get better after about 6 weeks or so. But the first couple of weeks were quite stressful because with that degree of swelling, you don't know if they're going to infarct the nerve, etc. But so, yeah, I do think there is every case of IIH I see, I do go through a mental checklist of, is there a cause for it? That's essentially how I landed with picking this up as a potential risk factor.
Thanks, Neha. I was just wondering, because that's our question when I discuss with the fellow from the UK, is that why is it, what is the link between the between ET and IIH? And in this case report that I found, it's speculated that possibly it's from intermittent cavernous sinus thrombosis from the ET. But from your other case reports, did they postulate any hypothesis as to why is it causing IIH?
Look, firstly, I don't think the thrombosis, because the other case reports, and including this patient we had absolutely no thrombosis. And her dad, who I said is medical, is actually a neuroradiologist. So there is definitely no thrombosis. But in terms of potential mechanisms, look, there were literally only 3 or 4 reports, and it is really difficult to know. And I suspect it is to do, in term with the clearance of CSF. And so there is extramedullary production of the cells, I suspect, but they're not translating into a pleocytosis of the CSF. Okay, so there must be something to do with the myeloid cells of the line of your bone marrow is often the one that causes more of a hyperviscosity syndrome than the lymphoid ones. And that could potentially, again, it's just the clearance of the CSF is potentially what we are seeing as a problem. Maybe more of the interstitial fluid within the CSF that now we do talk about a bit more is where the at the perivascular level, so rather than at a microscopic level as opposed to macroscopic, resulting in just congestion and increased in-race pressure. So I think the ultimate pathophysiology is still leading to what we see in IIH. So she's presenting exactly like IIH. And that's why I'm not even calling it the etiology, more a risk factor. It's, it just in terms of finer nuances. So I think that's my best guess. I don't think I can be any more definitive based on my N of 1 and a literature review of 3 cases. Yeah.
Thank you very much. That was a fantastic case. Neha, thank you for your commentary. It's very insightful. Joe, nice case, nicely presented. Thank you. I'm going to ask our next speaker to present on tuberculosis-associated optic neuropathy. Joe, if you don't mind, if you're still screen sharing. Yeah, thanks very much. Salma, would you mind?
Yeah.
I'm sorry, we've intruded into your time a little bit, but the discussion
No
was so.
problem.
Thank you very much.
Thank you. Okay, let me share my screen first.
Salma, if you don't mind, just introduce yourself in terms of where you are and your position, if you don't mind, for particularly people here in Australia. We'd love to know your sort of situation.
Okay, hello everyone. My name is Salma. I'm a neuro-ophthalmologist from Jakarta in Cipto Mangunkusumo Hospital. Yeah, today, thank you very much, Prof, for the invitation. I would like to share about this topic. This topic is talk about the hidden cause of TB treatment, toxic optic neuropathy. So let me share, let me start with a case illustration. So our case is female, 25 years old, with progressive blurred vision of both eyes for 2 months. She experienced fog blocking the central vision with glare of both eyes in the last 2 months, with no red eye, no pain or headache, and no history of eye surgery and spectacles. And she denied any history of smoking, diabetes, diabetes and hypertension, and no family history of ocular disease and blindness. So from 2011, she experienced small lump in neck and calf, night sweat and weight loss, and diagnosed as TB and got anti-TB drugs unregularly for 6 months. And 7 years later, she diagnosed as lymphadenopathy TB and received treatment for a year. And then in 2021, the lump ruptured with persistent cough, and the biopsy showed that she had rifampicin resistance, so diagnosed as MDR-TB. And then she got MDR-TB treatment, which consists of linezolid, triglycerin, levofloxacin, and she got also multivitamin. And on March 2022, the blurred vision, she experienced blurred vision 6 months and getting worse on 9 months of treatment and referred to our hospital. So this is our examination from both right eye, 1 meter finger counting, and left eye, 3 meter finger counting, with hyperemic optic nerve head. I'm sorry, we didn't have the fundus photograph, but the visual field examination showed sequocentral scotoma, and the left eye, and right eye is generalized depression. However, this is low test reliability examination. So she diagnosed as toxic optic neuropathy of both eyes due to linezolid, and we suggest the pulmonologist to switch linezolid to other drugs, and she also got multivitamins, citicoline, and zinc supplementation. So during follow-up, the visual acuity is increased at until 12 months. She got her visual function back, and the optic nerve had become pale at 12 months. So this is the first month, the second and third month visual field examination. We can see the improvement of field defect. And in the first month, we also checked for ganglion cell OCT, and it revealed borderline thinning in both eyes. Okay, and then our case number 2, male, 61 years old, progressive blurred vision of both eyes since 8 months, with no red eye, no pain or headache, no history of eye surgery or spectacles. History of smoking or hypertension was also denied, but he had type 2 diabetes mellitus and no family history of ocular disease and blindness. He already undergo treatment for pulmonary TB and got regimen of ethambutol, rifampicin, isoniazid, and pyrazinamide for initiation phase and continued phase with ethambutol, isoniazid, and rifampicin every day. So the visual acuity of both eyes was 3 meter finger counting. The optic nerve was normal, both eyes, and while the Humphrey examination, it revealed generalized depression of both eyes with mean deviation is about 25 decibel and 24 decibel in the right eye. So he diagnosed with toxic optic neuropathy due to ethambutol, and we plan to stop the ethambutol, suggested the pulmonologist, of course, and give with citicoline and zinc supplementation. And from the follow-up of until 3rd month, we can see the fundus was going to become pale, optic atrophy. The visual acuity of right eye improved to 6/30, while the left eye is still in 3 meter finger counting. And while the Humphrey visual field The left eye is quite the same, but in the right eye, we can see the visual field is improved to mean deviation 20 decibel. So I continue with the review and literature review. So tuberculosis remains a global health problem, and Indonesia has the second largest tuberculosis burden globally, with an estimate of 970,000 total incidents. Anti-tuberculosis drugs, namely ethambutol, isoniazid, streptomycin, and linezolid, are well recognized for its ocular toxicity, adverse effect, and fixed drugs combination do take away the flexibility of modifying or eliminating dosage of single drugs like ethambutol. And ethambutol toxicity causes the potential permanent bilateral visual loss, as WHO suggests give recommendation for giving ethambutol not only initiation phase but in continuing phase, so it will increase the risk of ethambutol toxicity. The prevalence of ethambutol optic neuropathy is about 1 until 2%, while linezolid is higher, about 6 until 13%. And the higher risk patient is older patient, more than 65 years old, a low body mass index, abnormal kidney, and HIV positive. And estimated prevalence of ethambutol optic neuropathy is increased with dose dependent. In more than 25 milligram per kilogram body weight, we can see the prevalence is increased to 5 until 6%, while more than 35 milligram, the incidence is about 18 until 30%. Typically, the symptoms occurred in 2 until 5 months after beginning the ethambutol therapy, but it can as late as 12 months. Linezolid, it's more than that, 1 year of consumption. Study by Brandaris et al. Showed the signs and symptoms occurred in 8.5 months. So this picture showed the pathophysiology of ethambutol optic neuropathy. Mechanism is unknown until now, but ethambutol, however, ethambutol inhibits microbacterial cell wall synthesis by disrupt oxidative phosphorylation, and then after that, it also increase the oxidative stress and lead to apoptosis of cellular injury, and then after that, retinal ganglion cell death and optic nerve damage, and can cause the vision loss. Meanwhile, in linezolid, the pathophysiology the linezolid inhibits protein synthesis by preventing ribosome complex. This graph showed about the genetics of ethambutol-induced optic neuropathy. Nowadays, we can see that some of ethambutol optic neuropathy, we can see there are, after the incident of optic neuropathy, there are lung or autosomal dominant optic atrophy. Why it could be happen in this graph? It can show that in lung there were mutation, DNA mutation of 11778 and 14484 and 3460 in mitochondrial DNA, and also mutation in OPA1 gene and MFN2. It will that located in central nuclear DNA, and it can hence the incidence of ethambutol optic neuropathy. And this is the summary of its study, including the genetic of ethambutol-induced optic neuropathy. In this study, we can see that a patient with ethambutol optic neuropathy, and if we check the mutation of one, we can detect the DNA mutation on those patients. So it concludes that ethambutol is a pharmacological that can precipitate the sign and symptom of mitochondrial optic atrophy, optic neuropathy. And how about the clinical manifestation of the toxic optic neuropathy? Is it gradual, progressive, and painless visual loss, bilateral, and symmetric? Usually, the patient will complain of this chromatopsia at the beginning. Pupil response run normal at early stages and RPD in asymmetric or advanced cases. And fundus at initial stage were normal or athalamic. And at the end, at the left stage, we can see optic atrophy. So the recommendation for screening for toxic optic neuropathy is color vision, contrast sensitivity, visual field, OCT, retinal nerve fiber layer, and CEP if available. And it is mandatory to do imaging with brain MRI, contrast brain MRI to exclude compression lesion. This is the typical visual field defect in toxic optic neuropathy due to tuberculosis drug, which is central and sequocentral scotoma, but we can also find bitemporal scotoma, like in this case. At the beginning, the bitemporal scotoma is very dense. At the last follow-up, it were partial recovery. And OCT, it's very important. We can see the thinning of aranopel in the first notice in infratemporal, supporting the involvement of papillomacular bundle. And study by Jin et al. Showed the subclinical ethambutol optic neuropathy, the extent of 20 until 30 micrometer increase or decrease from the mean of thickness at the baseline should be regarded as significant changes. So we have to monitor with special care. This diagram is showed us what we should do if we find patient with bilateral visual loss. So we have to exclude any refractive error, media opacity, and macular problem, trauma, or high-dose radiotherapy. Is there any painful in eye movement or pupil edema? And also, is there any papillary telangiectasia that conclude to one? Any family history of an unexplained visual loss that can cause hereditary optic neuropathy or history of cancer, ataxia and hearing loss or diabetes, anemia and polyneuropathy, and is there any history of alcohol, smoking, or transminase high, and potential toxin drugs. So we have to ask patient about this question and examine is there any sign that we can exclude any other possibilities. If the potential toxin drug is positive, we suspect with toxic mitochondrial neuropathy and stop the drug if possible. After exclude other possibilities. Okay. Until now, there is no effective treatment for tuberculosis drug optic neuropathy except stop the drug. And from the hypothesis, ethambutol optic neuropathy resulted from inhibited lysosomal activation due to chelation of zinc. So zinc supplementation was recommended. And the additional use of coenzyme Q10 for ethambutol optic neuropathy showed that it has protective effect on retinal ganglion cell on animal model. And citicoline also can suppress the damage of ganglion cell. And if there is no improvement within 4 until 6 weeks after stop the ethambutol, we have to stop other drugs such as isoniazid or linezolid. It should be considered. Recovery for visual function is most often partial or incomplete. And on average, patients who recover vision will improve 2 lines on Snellen chart. About 50% showed visual acuity improvement, while about 79% showed visual field improvement. And visual acuity was poor in older patients. And the prognosis factor, the important thing is initial visual acuity. If initial visual acuity is very poor, the prognosis is also poor. And optic atrophy on presentation is poor prognostic. This literature review of 18 cases of linezolid showed us that the time recovery needs within 15 days until 5 months, and the result, the outcome after treatment, this review showed the residual defect is still existing in some of cases. Okay, how about in our center? Dr. Diarani already conducted retrospective descriptive study. She analyzed 52 patients in our hospital with ethambutol optic neuropathy. So this is the result. The incidence of women and men is quite the same, and the site of infection was pulmonary TB, and the systemic disease was quite high in diabetes and hypertension. It's about 40 and 47%. And from the chief complaint, about 90% showed bilateral blurred vision, and most of patients came with normal or hyperemic disc in about 50 and 28%. And the RAPD, about 82% was negative due to bilateral involvement. And in this study, she also conclude that the visual field is about -14 decibel, and the RNFL is is about 107 micrometer. So the patient in the study got several therapy. The first one is stop ethambutol and 6 supplementation acetylcholine. About 12 patients got stop ethambutol and only acetylcholine. 5 patients got stop ethambutol and zinc supplementary, and only 3 patients only got treatment of stop ethambutol. And from the visual acuity, we can see there was improvement post-therapy with p-value is significant, less than 0.05. So this is the screening recommendation from the consensus guideline. Patient need to be referred for baseline ophthalmology examination for high risk for developing ethambutol toxicity, such as old age, low weight, malnourished patient, renal disease, TB, coexisting diabetes, tobacco or alcohol abuse, and preferable children. And patient who receiving combined therapy with linezolid higher than 15 milligram per kilogram body weight and prolonged ethambutol therapy. And the baseline evaluation are visual acuity, visual field test, color vision, and contrastivity. If available, we also check for OCT, RNFL, and VEP. And VEP, it will show abnormalities in amplitude and latency in P100, and delay latency is early biomarker. And Dancy et al. Recommend to screening within 1 month after initiating tuberculosis drug and subsequent evaluation every 1 to 2 months from initiation. As a take-home message, toxic optic neuropathy is a disorder characterized by damage of the optic nerve due to toxin, including anti-tuberculosis drug, which is dose and duration dependent. and physician should educate the patient regarding the ocular toxicity of ethambutol before its initiation. And the characteristics of the toxic optic neuropathy due to tuberculosis drug is gradual progressive painless vision loss that is bilateral and symmetrical of a central vision. And the prevention of ocular toxicity and management with early discontinuation of the drug are the only effective strategy. These are our references. Thank you very much for your kind attention.
Thank you very much, Salma. That was a great presentation and really interesting, especially the figures on the numbers of patients you have with TB, and to do a survey just in your one hospital and come up with 60 patients with ethambutol optic neuropathy is amazing. I'm just going to go to chat and see who has some questions. We don't have any questions at the moment, but I'm going to be cheeky and ask a question to Neha. Neha, do you see much TB drug-related optic neuropathy? I know I've seen, I think, 1 or 2 cases of ethambutol, but I'd never heard of linezolid. I'm going to say it.
Look, obviously for our population, we don't see a TB related. However, I have had a couple of patients at Royal Perth, one of linezolid and a couple of ethambutol. But these ones were, one of them was on MAC, so Mycobacterium avium complex infection. So they tend to also be treated with linezolid and ethambutol sometimes. So I have seen linezolid, but I must say from memory, the one with the linezolid did not quite recover. Yeah. But that again, I mean, obviously, you have a lot more experience in Indonesia with that in terms of recovery statistics. I was actually interested to know whether, following these patients up with OCT, RNFL-GCL versus VEP, is there any advantage of doing a VEP over OCT? Because we generally tend to do just the OCTs. And we will sort of, with ethambutol, I suppose, also do the VEPs, but I'm just not sure whether you pick it up earlier with VEPs compared to, by the time you already have the RNFL-GCL loss, you feel like it's quite late to then, you want to pick it up before you have those.
Okay. Yeah. Thank you, Neha. So, there are no best biomarker actually in toxic optic neuropathy due to tuberculosis drug, for example, ethambutol. But in ethambutol optic neuropathy in OCT, in the first, in the initial phase, there are longitudinal study that following the patient with ethambutol, it showed that the RNFL thickness is increased in initial phase, but no complaint. Patient was no complaint, no color vision disturbance, contrast, or visual field, or any visual acuity. So we cannot stop this at this stage. So this is called subclinical ethambutol optic neuropathy. Yeah. In my slide, I said about 20 until 30 micrometer. It is, we have to be cautious in this type of increasing and of RNFL. And if there was a visual field defect or visual symptom, other visual symptom like visual color vision or visual acuity decreasing, so after that we have to stop the ethambutol. Yeah, and the VEP also in the early phase, it can show any latency, prolong of latency in P100 as well. But from the recommendation, we cannot suggest the patient to stop in subclinical ethambutol optic neuropathy. But we have to screen regularly. Yeah.
Yeah. Yeah. I think it all depends on the, you're treating it for a life-threatening condition as
Yeah.
sight-threatening. There are situations where, and it's interesting, the RNFL thickens actually. I've thought about that before, and like you were pointing out with the mitochondrial dysfunction with LHON, etc. You have that subacute phase of, when it's a mitochondrial toxicity, this is obviously related to the drug, but when you have LHON, you have that subacute phase of pseudodiscedema where the RNFL thickens initially, and then later on it sort of gives in and you start to see loss.
Yeah.
Okay.
That is a curious observation in that the monkey experiments with monkey models of glaucoma show swelling of the ganglion cell axons within the laminar region. So it's almost like a response to hypoxic or injury. And I think Leber's hereditary optic neuropathy shows something a little bit similar. But trouble is I virtually never see those cases. But it almost seems like a first response of the ganglion to some kind of injury where I'm getting the mitochondria are dysfunctional and leading to localized swelling before they die off. But it's interesting you can actually measure that with OCT.
Yes.
Now, there is a question which relates to what you and Salma have just been talking about. This is a question for Salma. Good evening, Salma. I'm Dr. Kuril from University of Indonesia. Is there a protocol for regular vision monitoring during TB treatment, especially for those receiving a regimen containing ethambutol and linezolid? So I guess the question is, you're not in a teaching hospital, what would be the routine protocol that you would recommend for someone out there whose patient is on ethambutol or linezolid?
Yeah, thank you, Prof, and thank you, Dr. Hoiro. So actually, our recommendation for TB patient who got TB treatment is do the screening at the baseline before initiating treatment and continue within every month. So within every month, we check for regular vision monitoring. We check for visual acuity, visual field, contrast sensitivity, and also color vision. However, in our national guideline, we still finish it, our national guideline, to do this recommendation. So we have to check at the initial or within 2 weeks, the patient got the treatment. And then after that, every month until the patient finish the drug of consumption. So the screening we can detect early the optic neuropathy. Hopefully, the patient the visual function was good in all TB patient. As Indonesia is an endemic for TB, we have so many patients with TB disease.
Yeah, what do you do? Because you said the prevalence was something like 960,000, which is, I mean, virtually 1 million people with TB at any one time, it would seem. How it's a huge problem. I'm thinking, have you tried sort of mass screening with tablet-based color vision charts or visual field charts, or are there any kind of cheap mass screening type procedures you can do? Because I've got this image of 1 million people coming to see their local ophthalmologist for visual field testing and color vision testing. especially in remote locations. Are there any tips or tricks that you might suggest? And this is, and I'm not expecting a sort of super clever answer, because it's a big problem that affects glaucoma as well. We don't have there's no easy solution for this type of screening for glaucoma, but I'm wondering if you've had any thoughts on this, Salma.
Yes, Prof. So yes, this is a burden problem for us. So our national guideline actually do recommendation is simple for everyone, especially in remote area. So we have to check the visual acuity with Snellen. If the patient use glasses, so we check for visual acuity with glasses, and also we do the color vision check with the Ishihara test. So in not only in hospital but in puskesmas, we say puskesmas, it is a facility, health facility, small health facility in remote area, we call puskesmas. So it only has several instruments like Snellen and Ishihara. So the recommendation is to do Snellen visual acuity, Ishihara test, confrontation test. Yeah, that's all.
Thanks very much, Salma. Thank you. At least the Ishihara, I'm not sure how. Well, the cases I've seen, they seem to have reduction in Ishihara color vision, but I've only seen less than a handful, so I don't really know. There's one more question. Good evening, Dr. Salma. Thank you for your presentation. I'm Amani from University of Indonesia. I'd like to ask, in patients on a regimen of more than one medication that causes toxicity, should we always stop the ethambutol first? And if there's no response after 6 weeks, which medication should we then stop? And also, is it possible to stop both drugs, I think they're meaning linezolid as well as ethambutol, at the same time?
Yeah, okay, thank you, Prof. Thank you, Dr. Amani, for the question. So yes, if the patient got the first line of TB treatment, which consists of ethambutol, isoniazid, pyrazinamide, and rifampicin, we first suspect the toxicity drug come from ethambutol. So we stop the ethambutol first, and then we check for another 4 until 6 weeks. And if there is no improvement or worsening, so we have to suspect that is there any possibilities that drugs can cause the toxic optic neuropathy. So if the patient also got isoniazid or linezolid, we should also stop the isoniazid or linezolid. So yeah, but we cannot stop at the same time. Actually, we have to because the patient still need combination therapy for TB. Yeah, and the pulmonologist will switch to other drugs actually. So we cannot suggest 2 drugs at the same time.
Right. Thank you.
Can I ask a question, actually? Are there any patient characteristics, specifically, let's say genetic or something on those lines, is what I'm alluding to, that would make someone more likely to have toxicity with ethambutol versus someone who doesn't have it? And is there sort of role for screening for that? Because from memory, I know you said that there was related to the dose, but isn't it also considered idiosyncratic? Like sometimes you just have the toxicity at a certain level, and then obviously with the increase in dose, you might accumulate that more.
Yeah, it's yeah, it's interesting about the genetic issue in toxic optic neuropathy. It's actually the genetic is still studied until now. So from the conclusion from the review study, it's associated with mitochondrial DNA gene, such as LON and dominant optic atrophy.
Yeah.
So yeah, this kind of two also increase the possibility patient got the toxic optic neuropathy due to ethambutol. In other, also after the patient got the ethambutol, it also increased the risk of the one will the one will become symptomatic. At the beginning, yeah, the patient is asymptomatic.
Sort of a double hit, yeah.
Yeah.
Yeah. I mean, given the numbers you have, what proportion of patients that go on TB treatment end up with ethambutol toxicity, I suppose? Is it quite a small proportion or?
Actually, we don't know yet because it is in only our hospital. Yeah. Our hospital is referral hospital. Some of patients probably will come to other hospitals. So I think it's quite high, the prevalence in our country, but the number we don't know yet actually.
Thank you. No, it's really interesting.
you.
Again, you have such a vast sort of experience in this, and we will only go by what you're able to report for us. Yeah.
Yeah, thank you.
Yes, your numbers are amazing, actually.
Yeah, absolutely.
That's now I've got a really dumb question to ask, Salma. Does TB affect the optic nerve in any other way? Does it ever have direct effects upon the optic nerve? Right, this is.
Sorry, sir. Could you repeat the question?
Oh, yeah. Sorry. Does tuberculosis ever have a direct effect upon the optic nerve? So we've been talking about treatment toxicity from TB, but this is a really dumb question. I don't know the answer to this, but do you know if tuberculosis causes optic neuropathy itself in some way? I'm doubting it if it actually infects the optic nerve very often, or yeah, and I'm wondering if you've come across cases.
Yeah, we also have patient with TB, optic neuritis due to TB. Yeah, the patient can have blurry vision, only one or both eyes, but the sign and symptoms it's not the same with toxic optic neuropathy. Usually, it is subacute visual loss. Subacute visual loss, sometimes with pain, with this eye movement. And we also check for the usually the individuals also had a self-vitreous, and in the optic and the retina there was also not only edema in the optic nerve but also exudate in the retina. Yeah.
Right. So I think what you're saying is that usually you find other ocular signs. Would that be correct in a patient?
Yeah. We have to differentiate with toxicity.
That's
optic neuropathy.
That would be interesting. I mean, on the other end of the spectrum, we get TB meningitis. So that can obviously cause leptomeningeal disease around the optic nerve sheath as well.
Yeah.
And as you said, the optic neuritis can be enhancing on sort of GAD on MRI, which would be different to a toxic optic neuropathy.
Yeah, it will be different management as well. So yeah,
Okay.
so we have to continue the drug first.
Look, thank you. It's been a fascinating evening. And the whole topic of optic neuropathies, especially related to TB, is fascinating. Salma, thank you very much for a really excellent talk. You covered the clinical cases, the pathophysiology, the relationship and the investigations, and the sequence of testing was just so clear and succinct. Neha, thank you so much for joining us, and your questions and commentary on both the IIH and the TB drug treatment was fantastic. And I think Jo Koo had to actually leave early to go to another meeting, but I'll thank her later. But thank you, everyone. Now,
Thank you.
Mita.
Yeah.
Oh, yeah, absolutely. It was a really fun meeting.
It was really interesting. Very interesting, actually.
Mita and Artie, now I know that you like to take a photograph of everyone who. And this
Yes,
is
thank
at the,
you, Prof.
um,
Maybe Dr. Miki can help us to capture the picture.
Yes, Dr. Mita. Everyone, I would like for you to open up your camera, please, so that we could conduct our photo session. We will begin the photo session in about 10 to 15 seconds, so please open up your camera. Okay, I think I will start taking the photos now. Everyone, give us your best smile. 1, 2, 3. Okay, second page. 1, 2, 3. Third page. 1, 2, 3. Fourth page. 1, 2, 3. Okay, that would be all. Prof. Morgan, back to you. Thank you.
look, thank you. All I've done is sit and enjoy the show. Again, thank you, Salma and Neha.